Hello, everyone, and welcome to today's webinar, Measles Matters, Understanding the Outbreak and the Lab's Critical Role. I am Cassie Soltman of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by DiaSorin. To learn more, visit diasorin.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation. You may also use the Ask a Question box to let us know if you're having any trouble seeing or hearing the presentation. I'd like to now welcome our speaker for today's webinar, Dr. Ben Bradley, Medical Director at ARUP Laboratories. Dr. Bradley, you may now begin your presentation.
Hello, everyone, and welcome to today's seminar entitled Measles Matters, Understanding the Outbreak and the Lab's Critical Role. My name is Ben Bradley, and I'm an assistant professor in the Department of Pathology at the University of Utah. I'm also a medical director of virology and molecular infectious disease at ARUP Laboratories. Before we get into today's lectures, just a brief disclosure. I have received some speaker fees from DiaSorin for today's presentation. However, I will not be mentioning any specific manufacturers today. As far as our learning objectives go, first, I want to describe the current state of the 2025 U.S. measles outbreak and some of the barriers that we face that have prevented us from controlling the spread of the virus. Also, I want us to recognize the clinical features of measles and the role that vaccination plays in reducing the spread of the virus. Also, I want to examine the role for clinical testing in the diagnosis of measles and look at how some of these diagnostic methods have evolved over time. So let's just discuss measles virus in general. Measles virus is a member of the Paramyxoviridae family of viruses, and this includes some other viruses that you've probably heard of, such as mumps, RSV, and parainfluenza virus. The genome of measles virus is fairly simple. It's small at 16 kilobases. It's a single-stranded genome of negative sense RNA virus, and that genome includes 6 structural proteins and 2 non-coding proteins, or non-structural proteins. And the most important proteins we should really discuss for today are 2 of the proteins on the surface. The hemagglutinin protein, which actually functions very similar to the hemagglutinin protein of influenza virus, in that this allows the virus to bind to the cell, and then the fusion protein on the surface of the virus, which allows the viral envelope to fuse with the cell membrane and allow the virus to infect the cell. Now, with measles virus, as opposed to something like influenza virus, there's just one antigenic type. And what this means in practical terms is that we don't need to re-engineer a seasonal vaccine every time for measles virus, that the genome is stable enough and the proteins are conserved enough that the vaccine that we developed decades ago is still effective today. Another important thing to know about measles virus that is different from some other viruses we see is that humans are the only reservoir for measles virus. And so what that means is that measles only spreads between humans. It won't infect any other animals, and it doesn't really persist in the environment for extreme amounts of time. So what this means to us is that if we're able to prevent the spread of measles between humans, we can eliminate measles virus. Measles virus has got a lot of attention in the news lately because of outbreaks that have gone on. But measles virus also has some very unique features about it that can make it dangerous and able to spread very easily. And what's unique about measles virus is that it can be transmitted as both droplets and aerosols. Now, those 2 words might kind of sound pretty similar to you, and it might be difficult to know what the difference is between them. But in practical terms, it kind of describes the size of the particle and how far they can spread. So for something like droplets, we think of these as very relatively large, heavy kind of molecules that will fall to the floor very quickly. Whereas aerosols are these micro droplets that can stay suspended in the air for long amounts of time. And in fact, we can see this figure over on the right here, where with these large droplets, these typically only stay in the air for about 5 seconds. But for these smaller aerosolized particles, they can stay in the air for over 12 hours. And so what this means for the spread of measles is that you can become infected by somebody who has measles, even if they're not in the room at the same time as you. And so that can be very challenging to help us try to control the infection. In practical terms, this also means that for patients who are hospitalized with measles, they need to be placed on airborne precautions, which are a higher set of patient controls than we would see for somebody who has maybe something like influenza virus, where we just need droplet precautions. For folks who work in the laboratory, measles is also a big concern for us because we have to make sure that we minimize the number of aerosol generating procedures that we might do with the sample. And if we are handling that sample, we really want it to be done in a BSL-2 hood that can control the flow of air. So in addition to measles' ability to spread as small droplets and aerosols, measles is also very infectious because of its R0 value. And this is a number that's assigned to different pathogens based on how many additional patients will become infected from one case of measles. And so in this situation, we see the R0 value for 3 different pathogens here. For COVID and flu, where it's 1 to 2. And so what this means is for each patient who has influenza, they may infect an additional 1 to 2 people. For pathogens that are of a little bit higher concern, like polio and smallpox, typically we see the R0 values for these between 5 and 7. So someone who has polio is likely to infect another 6 people on average. Measles, of all the human pathogens, has the highest R0 value known at approximately 12 to 18. And so what this means is that for every person who has measles, they will potentially infect another 15 people. And this really makes a lot more sense in how threatening measles can be when we look at how the cases can compound over time. So let's look at what happens over kind of 3 waves of spread of the virus. And we'll look at each 3 of these pathogens. So we'll start off with patient 0, so 1 patient who has each of the diseases. After the first wave, we'll see that there are 2 people who have flu now, 6 people who have polio, and 15 people who have measles. And as we bear this out over 2 more cycles, what we'll see is that by the time we get to wave 3, there are over 3,000 cases of measles that have happened in comparison to 3 for influenza or 216 for polio. So just over those 3 generations, measles has proved to be 1,000 times more effective than influenza. And what this means when we think about kind of monitoring for disease in the population is that measles can serve as kind of a signal event or a canary in a coal mine for us. Because measles is so infective, what this means is that when vaccine coverage starts to drop in a population, the first pathogen that's going to start to break through is measles because of its transmissibility. Now, despite the threat of measles virus and its infectivity, we do have measures to counter it. And the most effective measure that we've had is vaccination. And you can see this chart over time of the number of measles cases, and you can see the impact that vaccination has had, how in less than a decade, we were able to nearly eliminate measles virus. And over time, after that initial reduction, there were several small peaks. And then in the late 1980s, there was a recommendation for a second dose of the measles virus vaccine. And what we found was that that first dose was about 91% effective, and the second dose raised the effectiveness to about 97%. And so here are just 2 studies from kind of the early 1990s when we were looking at using 1 dose of the vaccine versus 2. And you can see in school-aged children, those who received 2 doses of the vaccine, there were very few infections compared to those who just received a single dose. And then in the year 2000, measles was declared eliminated in the US. And what elimination is defined as is the absence of endemic measles transmission in a region for greater than 12 months. Now, while from 2000 to 2020 and 2025, the case volume may look flat on this graph, there are some cases that have occurred over time. And here's just a little bit of a breakout of those cases over time. And you can see we've had a few peaks before this outbreak that we're experiencing in 2025. Most notably in 2014, there was several cases that occurred in Disneyland. There was also an outbreak in Ohio that occurred. And then in 2019, a very large outbreak in New York that has happened, in addition to the cases that we're experiencing in 2025. So now we have to ask ourselves, why is this happening? And there are many reasons why we are seeing a resurgence of measles, but what it comes down to at the end of the day is one number, and it's a number that I want you to remember moving forward from here. that is 95%. So why is 95% important? 95% is the vaccine coverage that we need in order to prevent the spread of measles virus. And as I mentioned, measles virus only infects humans. So if we can prevent the spread of the virus, we can eliminate the virus. Now let's start off by looking at a map of vaccine coverage of the US. And this is from the 2019-2020 school year. And what we want to see is mostly blue everywhere. Blue indicates greater than 95% vaccine coverage in kindergartners. And there are only 2 states here where we see less than 90% vaccine coverage. But let's fast forward now 5 years to the 2023-2024 school year. There's much more yellow and orange here, much less blue. So vaccine coverage has dropped over time. And in fact, what we have seen is that over the last 5 years, the national vaccine coverage for kindergartners has decreased from 95.2% to 92.7%, below that level that's needed to prevent the spread of measles virus. Now, you might say, okay, 92.7% versus 95%. Is that really that big of a deal? Well, yes, because that's going to effectively allow cases to pop up over time. But what's more important is that vaccine coverage in communities is even lower than that. And measles outbreaks don't happen necessarily at a national scale. They happen within communities. They happen when someone travels to an area where measles is circulating, and then they bring that case back into a population that has low vaccine coverage. So let's just look at kind of how community level vaccination levels can also impact the spread of measles. So for instance, if we take my state of Utah, the estimated vaccine coverage here is 88.8%. So about 11.2% of individuals are unvaccinated at the state level. But if we break this down to the county level, then we see there are some counties where almost 20% of individuals are unvaccinated. But we can go even more granular than that too, and look at individual school facilities. And what we can see here are at least 4 facilities where over 30% of those individuals are unvaccinated. So when we think about someone who's infected with measles virus coming into these communities and knowing that R0 value of measles, knowing how it's transmitted through aerosols, it's very easy for measles cases to be established in these communities and cause large outbreaks quickly. In addition to global challenges with vaccine coverage, part of the challenge in the US is that we have a very patchwork adoption of vaccine requirements and reasons for exemption. So in the US, there are only 5 states that have banned non-medical exemptions for the MMR vaccine. And at least 2 of those states have done that in response to measles outbreaks. So for example, in 2015 in California, there was an outbreak in Disneyland, and there was over 140 US cases that were identified that were eventually linked to outbreaks in 7 states. In addition, there was a traveler who went from California back to Canada that led to an outbreak of another 159 cases. And so in response to this, California eliminated personal exemptions and religious exemptions for vaccines. Also in 2019, New York had a very large outbreak in a religious community with 649 cases. And within this group, there was less than 15% vaccine coverage. New York went so far as to actually require 4 zip codes to be vaccinated or face fines if they didn't. And when New York went ahead and eliminated any non-medical exemptions, what you can see here is that it had a positive impact on increasing the rate of school vaccinations that children received before starting. Okay, let's move into the 2025 outbreak and sort of address where we are right now. This data is current as of August 20th. So we're currently at 1,375 cases, and this is the highest number of measles that we've seen in the US since 1992. And overall, there have been 35 outbreaks identified in 41 states. And an outbreak is defined as 3 or more cases that have been epidemiologically linked to one another. Of those cases we've seen in the US, about 13% of them have required hospitalization. And over 90% of the individuals who have developed measles are individuals who are unvaccinated or have unknown vaccination history. The largest outbreak that we've seen in 2025 is this cluster of cases that were found in Gaines County, Texas. So let's talk a little bit more about this Gaines County outbreak. So far, we've identified 762 cases that have been linked to this importation, and that's over half of the total measles cases that we've seen in 2025. This began in a Mennonite community that had low vaccine coverage, and since then, cases have spread to New Mexico, Oklahoma, Kansas, and have been imported to Mexico. There are also at least 2 known deaths in school-aged children. Now, there is some good news here in that the outbreak does appear to be over, and the way that we're able to figure out when a measles outbreak has ended is when 2 incubation periods of the measles virus have passed. So it takes up to 21 days for someone who's been exposed to measles virus to develop the disease. And so after we wait 2 of those periods, or 42 days, if we've seen no more new cases linked to that outbreak, we can say the outbreak's over. Let's go ahead and talk a little bit about measles virus and how it presents clinically. So measles virus starts off with an incubation period. That is when someone's been infected but is not presenting any clinical signs or symptoms. And the incubation period is about 8 to 12 days. And this can actually be very challenging for public health officials who are trying to control the spread of the virus, because someone who develops measles virus was potentially exposed over a week ago, and sometimes it's challenging to sort of trace where they were or for them to recall where they were over a week ago. Once symptoms do begin to develop in this prodrome period, which is kind of poorly defined symptoms, we see the 3 C's as kind of the hallmark features, and that refers to cough, conjunctivitis, and coryza, which is kind of stuffy, runny nose. But the most pathognomonic feature, or what we would look for to feel very comfortable about a diagnosis of measles in a patient, are Koplik spots. And these are little white plaques that can be seen on the inside of the cheek of patients who are infected with measles. And this typically begins a day or 2 before the rash develops. Another important thing for us to remember is that patients may be infective during this prodromal phase. So even though they don't maybe have classic hallmarks of measles virus, they can be spreading the virus. What has historically been used to define measles virus infections is the measles rash. That's really probably what you've seen in the textbooks, what you've heard the most about when you look at news articles. And this rash presents in a very kind of stereotypical way. So it presents in what's called a cephalocaudal manner, meaning that it starts at the nape of the neck and then proceeds down the body. And then the rash will resolve in that same order. The rash is often described as maculopapular, and what that really means is just a macula is a large spot, and papule means it's palpable. So these are kind of large raised splotches on a patient. And the rash typically appears about 4 days after the prodromal symptoms. But the most important thing to know about the rash is that patients are infectious 4 days before the rash develops and up to 4 days after. So when we're trying to monitor for patient exposures or control spread in the community, we really want to know when that rash started so that we can figure out when the patient is no longer infectious. So I've talked a little bit about how measles has this characteristic rash, but I think for any of you who have exposure to children, who have children, you know that kids get a lot of rashes, and some of these rashes can look very similar. And so just to present the challenge that a clinician might face, I have 6 different rashes up here for you, and I want you to try to figure out which one you think is measles virus. So I'll give you just a couple seconds to look at it before I reveal the answers. And so the one on the top left is measles, but other viral illnesses can also present with a similar type of rash, including rubella, HHV6, parvovirus B19, but also autoimmune conditions like Kawasaki disease or just drug reactions. Another big challenge in identifying the measles virus rash is that because measles has been so rare over the last 50 years, practicing clinicians aren't familiar with spotting the rash. And so they may think about another item on their differential before measles. Something else that I want to discuss is that measles is much more than just a mild rash and a mild upper respiratory illness. I think that's kind of typically what's shown, but we really need to understand how impactful measles virus can be to both patients and the community. So there are some common complications that we see with measles virus, and that includes diarrhea, otitis media, and ear infection, or pneumonia. But there are also very severe complications that can come from measles. And that includes things like hospitalization, encephalitis, infection of the brain, and of those, about 20% of those cases can be fatal. There's also a subset of encephalitis known as measles inclusion body encephalitis. And this is something that is uniformly fatal in patients who develop this. And then the risk of death associated with measles virus infection is between 1 in 3 people per 1,000 cases. There's also a very unique pathology associated with measles virus that I don't think gets discussed very much, but I do want to touch on just to make you all aware of. And it's called subacute sclerosing panencephalitis, or SSPE is how I'll refer to it. And what SSPE is a neurodegenerative disease that actually develops about 5 to 10 years after somebody's been infected with measles virus and recovers. Originally, it was thought that the incidence of this was about 1 in 100,000. But as we've gathered more data, as more outbreaks have occurred over time, we now think that rate's probably closer to 1 in 10,000. And for children who are infected with measles before they turn 5, that risk is probably closer to 1 in 1,000. And the pathogenesis of this disease is still a little bit unclear, but it's believed to be associated with the persistence of a defective form of the measles virus that exists in the brain and is able to spread cell to cell. And what happens in patients who develop SSPE is it's this kind of progressive neurological decline. So it starts with behavioral changes, and then there are some motor nerve movement disorders, but eventually it leads to a persistent vegetative state. And what makes this really tragic is it's uniformly fatal. It occurs kind of progressively over 1 to 3 years, and there's not any treatment that's available for it. So there's really nothing that can be done for these patients. In addition to the challenges that occur to patients who are infected with measles virus, there's also a larger impact to the community. And I want to highlight some of those community members that are disproportionately affected by measles. This includes pregnant women and newborns. And what I have here is a study that looked at 42 pregnant women who were infected with measles. And what the researchers found was that over 60% of these had at least one adverse fetal or neonatal outcome. And that included things like neonatal ICU admission or low birth rate. There was also a subset of these, about 25% of those pregnancies that were infected with measles, where there was either a spontaneous abortion or intrauterine fetal demise. And we can compare that with the control population, where it was seen in less than 5% of those people. Maternal mortality risk was also tenfold higher in the measles population than the normal population. Immunocompromised individuals are also another group that warrant special consideration when we discuss measles virus. And that's because the MMR vaccine contains a live attenuated form of the virus. And so for individuals who have a weakened immune system, their body is not necessarily able to control that attenuated virus very well. And so for certain individuals, like those who have a history of cancer or immunodeficiency or immunosuppression due to medication, they're not eligible to receive the vaccination. And so they need a high community coverage with the vaccine to be protected. Now, there are some instances in the literature where immunocompromised people have inadvertently received vaccination, and this can sometimes lead to severe pneumonia, encephalitis, or even death in some cases. So this is a group that is not able to receive the MMR vaccine. There's another interesting effect with measles virus infection, and that is this phenomena that's been defined as immune amnesia. And what this phrase really means is it describes a reduction in immunity to other pathogens that an individual experiences following a measles virus infection. The proposed mechanism for this is still kind of being worked out, but it's thought that following infection with the measles virus, it reduces the number of our immune cells or lymphocytes that produce antibodies. And that lower production of antibodies makes us more susceptible to other types of infections. And so I want to share this one study with you that kind of highlights the impact of immune amnesia here. And this was a study that looked at antibody production both before and after measles virus infection. So let's start off by looking at this group boxed in green, which are individuals who were not infected with measles or those who had the vaccine. And what you can see are their antibodies pre and post. So for those who did not get infected with measles, their antibody levels stayed about the same. Those that got vaccinated, they saw a little bit of a boost in their antibody levels. But for those individuals who had measles virus infection, what we can see is that their antibodies actually decreased following infection. And when this was quantified, the study authors found that there was an elimination of 11 to 73% of the antibody repertoire across the individuals in these populations. So, what does that mean in practical terms? Well, if we're having a reduction in our antibodies, that might make us more susceptible to infections by other pathogens. And so future studies looked at kind of the impact of measles virus infection on other infections, other infectious diseases. And this is a study here that used data from the UK, the US, and Denmark that looked at measles cases and then the number of non-measles infectious deaths per year. So it's a busy slide, but basically what you need to see is that as the number of measles cases per year increase, the number of non-measles infectious disease deaths also increase. And so what they were able to find was that in years with measles outbreaks, there were higher rates of death from other infectious causes. And it looked like the effect of these measles virus outbreaks persisted for about 28 months. There was another similar study that occurred in the UK, where they looked at over 2,000 children who had been diagnosed with measles between 1990 and 2014. And what you can see here in the blue are measles-infected individuals, and the red are uninfected individuals, with the y-axis showing the incidence of infections. And what these authors found was that in the first month after measles, those children who had measles virus had a 43% higher rate of infections. And this persisted over the first year, with the infectious rate being 22% higher and then 10% higher after that. For those individuals who had measles, they also had a higher risk of hospitalization, about twofold higher than those who were not infected with measles virus. The last thing I want to talk about now, as far as kind of the clinical picture of measles virus, is treatment. And I think the most important thing to stress here is that there is no specific treatment for measles. There's not a specific antiviral. The way that we can prevent this is through vaccination. Now, for those individuals who do develop measles, care is mostly focused on supportive care, controlling the fever, pain, and really monitoring for worsening symptoms that may require more intervention. You may have heard a little bit about vitamin A supplementation, and it is something that's mentioned in the AAP guidelines for treatment. Now, an important footnote here is that most of this data came from the impact of vitamin A treatment in children who were from developing countries or who had suboptimal nutrition. So how well this applies to a developed country or children who have adequate access to nutrition is uncertain. But what is important to remember is that vitamin A is not something that's harmless. In fact, vitamin A is a fat-soluble vitamin that can actually lead to toxicity in very high concentrations. And there were some reports from Texas about vitamin A toxicity occurring. And what we can see is that this can lead to changes in vision, liver damage, and even coma. So we certainly have to be careful about the use of vitamin A. This is something that requires provider supervision. Okay, let's move into discussing the clinical diagnosis of measles. And there's a few different diagnostic methods I'm going to highlight today. The first is going to be histology. We're then going to talk about viral culture, followed by serology and molecular testing. Now, of these four, serology and molecular testing are the two preferred methods by the CDC, but you may not have had as much exposure to histology or culture, so I'd like to touch on those as well. Let's start off with histology. And now I know that probably very few of you are practicing anatomic pathologists, so we're going to start off by just looking at what normal lungs should look like. And we can see that over here on the left. We can see some airways present here, these big spaces, and then this nice kind of lacy tissue here. These are the alveoli. These are the air spaces that oxygen exchange occurs over. And now let's compare this to a abnormal lung or a lung from somebody who might have measles virus infection or measles pneumonia. What you can see here is that this is much more pink, that these thin walls are a little bit thicker. And this picture, even at this high level, just suggests that there's some kind of inflammation that's going on in the airway, some kind of damage. And now if we look at a little bit closer images of this lung, we can see some traditional features of lung injury due to measles virus. Now, the common pattern for measles virus to injure the lungs is this pattern called diffuse alveolar damage, or DAD. Now, this is nonspecific, but it is commonly seen in viral infections. And DAD in the lungs histologically, the clinical picture we would see is a patient who has ARDS, or acute respiratory distress syndrome. DAD has a few important features to it. During the acute phase of injury, what we look for are things that are called hyaline membranes, and that's these kind of pink stranded objects here. These are just proteins that have seeped into the airway and have started to kind of congeal in the airway. Later on in DAD, we'll see something that's called chronic DAD, and this is highlighted by something called fibroblastic proliferations. And so these are groups of fibroblasts that have moved into the airway to try to clean up some of that inflammation, some of those hyaline membranes and debris. So this is the type of injury pattern that we would expect to see in somebody who has measles pneumonia. If we go back to our original picture here, we can look a little bit more closely at the tissue. And as we look more closely, we'll see a few more features. So we see that diffuse alveolar damage. We see some septal edema, which just refers to those alveolar walls becoming a little bit more thick. And you may also note some atypical cells. I'll give you a moment to see if you can kind of find those on this image. But I've pointed them out here, and we'll take a closer look at them now. So measles virus does have a characteristic cytopathic effect. Cytopathic effect is just the word that we use to describe changes in human cells that occur following virus infection. And the cytopathic effect we see with measles includes multinucleated cells, so cells that have many nuclei. Again, you can see almost innumerable here. Nuclear inclusions, so these purple dots are the nuclei, and then within them you can see a little bit of pink material, so that would be the inclusion. Also within the cytoplasm, we see these pink or eosinophilic inclusions. And then if we look at just kind of the overall appearance of these large cells, they're sometimes described as mulberry cells. Now, as far as the histopathologic diagnosis of measles goes, it's not technically sufficient to meet the CDC's case criteria, but if you were maybe a practicing pathologist who saw those kind of features, it might alert you to investigate further about whether this patient potentially had some measles exposures. Also, many viruses and some non-viruses can cause diffuse alveolar damage, so that pattern isn't pathognomonic for the disease, as well as the cytopathic effect that I showed you. Again, there are some other viruses like RSV and influenza that may appear similar as well. So what you really need to do to confirm the diagnosis of measles from histology is to use immunohistochemical staining or molecular testing to get to that diagnosis. Next, let's go ahead and discuss viral culture. Now, for those of you who maybe haven't been in the lab for 25 plus years, you might not be familiar with viral culture at all, but what this refers to is the growth of virus present in a clinical sample using in vitro cultured cell lines. And there's traditionally been two ways we've done this. The first is kind of traditional or tube viral culture. And this uses these round bottom flasks you can see here. They're typically seeded with cells, placed in rotating incubators, and inoculated with a patient sample. These are then observed for the development of cytopathic effect, but results may take up to 30 days. There's also what's called rapid viral culture. And with rapid viral culture, we use these 1 ml vials, or sometimes referred to as shell vials, with cells growing on the cover slip. And the advantage of this is that this lets us test for the presence of virus prior to the development of cytopathic effect. And we can shorten the time to results here from 30 days to about 10 days. So I've talked a little bit about CPE or cytopathic effect in tissue, but what about CPE in viral culture? What we're really referring to is when the cell monolayer changes from this nice kind of flat pattern with cells respecting each other's borders to some kind of change that indicates the presence of cells that have been infected with the virus. And this can include changes like detachment of the cells from the cover slip, syncytium formation, where cells begin to fuse together, cell rounding, where each cell starts to kind of ball up. And sometimes the cytopathic effect can be a little bit more subtle, where we just see small little pockets of cell change against a background of more normal appearing cells. In our own laboratory, we still do perform viral culture, and our process is illustrated here. Essentially, we take the specimen, we inoculate it into shell vials. Typically, we'll use 4 different cell lines to inoculate, and that's just because different viruses have different growth preferences for cell lines. These samples then have a slow speed centrifugation to help the virus infect the cells, and then we'll monitor over about 10 days for the development of CPE. And typically what we'll look for is in these cell lines that are initially negative, depending on the number of days that the virus takes to grow, we'll then see the development of cytopathic effect. And what you can see here is maybe some syncytium formation, some cell rounding. And once that CPE is present, we'll then use a monoclonal antibody to the virus to confirm which virus is present in the sample. And in this case, we would stain it with measles virus antibody and see a positive signal there. I mentioned how not a lot of folks are doing viral culture anymore, and you might say, all right, why should I even care about this? Why are we still doing this in a world where PCR exists? There are some advantages to this that still exist. And one is that viral culture can identify novel viruses or viruses that are not commonly tested. So, for example, in our experience with our viral culture, during the mpox outbreak 2 or 3 years ago, before we had a PCR test for it, we incidentally found mpox virus growing in some of our clinical samples that were sent for herpes virus culture. Another advantage of viral culture is it actually confirms the presence of infectious virus. Compare that to something like PCR, where it just tells you that the nucleic acid is present. And so confirming the presence of infectious virus was actually very helpful during the COVID outbreak when we were trying to figure out whether somebody who had COVID virus detected by PCR still had infectious virus in that sample. We can also use cultured virus for some downstream processes. This includes things like antiviral resistance testing and neutralizing titers. It can also allow us to amplify the virus to higher titers so that we can use it for sequencing, or if we want to produce it as kind of a reagent for positive controls for other assays. Let's move on to discussing serology now. And when it comes to serology, there are 2 main analytes that we think about for measles virus testing. The first is immunoglobulin M, or IgM. This is a pentameric antibody complex, just meaning that it has kind of 5 antibody units on it. And this is produced early in infection. When we're trying to diagnose somebody using IgM as an analyte, typically if we see IgM as present, we normally use that as a marker for acute infection. But there are some limitations with IgM, especially for measles virus. One is that IgM might not be detectable at the time of rash onset. Another challenge is that IgM can persist for several months, so you may still have a positive result in a patient long after they've resolved their measles virus infection. There can also be false positives that sometimes occur in response to EBV or parvovirus B19 infection. The other analyte we'll sometimes use is IgG, and this is the most common antibody found in circulation. It's a single unit, and it's part of kind of our long-term immunologic memory. The diagnostic criteria for this one is a little bit different. So to diagnose acute measles virus infection using IgG, we need to see a 4-fold increase in IgG titers or IgG seroconversion. But IgG is also useful if we're trying to determine if somebody had measles virus infection in the past or if they were vaccinated. The limitations we see with IgG, first off, is that if we're trying to diagnose acute infection, it really requires 2 samples collected weeks apart to see that either change in titer or seroconversion. And you kind of have to ask yourself, what's the diagnostic utility of figuring out somebody had measles virus, 2 or 4 weeks ago when you need to collect 2 samples several weeks apart? IgG is also not very helpful in the diagnosis of measles in newborns, and that's because IgG can cross the placenta, meaning that mom's IgG antibodies can be found in the baby. Finally, titers might not always be available for IgG. In order to do that, you may need some kind of quantitative assay or do virus titer in culture, and many of the assays that are available won't provide that kind of information. It's also helpful for us to know the kinetics of measles virus serology. So immunoglobulin M, or IgM, is typically negative in the first 3 days after rash onset. The best window with the highest sensitivity is typically 6 to 14 days after rash onset. And then these begin to decline about 30 days after infection. And typically we don't see them by 3 months. For IgG, its onset is a little bit delayed. Typically we see the best sensitivity around 7 to 10 days. But in comparison to IgM, IgG antibodies are long-lived, and they're thought to last for your entire life. So if you've received 2 doses of the MMR vaccine, you're considered to be protected for life. Now, there's a very small minority of people who may seroconvert, and what that means is going from IgG positive to IgG undetectable per year. However, even for those individuals who do seroconvert, data has shown that these individuals, if they are re-exposed to measles virus, will more quickly produce IgG antibodies to protect them from infection. So that's just something to keep in mind as well. When it comes to interpreting serology results, it's fairly straightforward. We can kind of look at this on a per analyte basis. So if IgM is positive only, we feel pretty comfortable that's an acute infection. If both IgM and IgG are infected, we think this is still likely an acute infection. It may just be a little bit later in the disease course. So again, maybe day 6 or 7 after rash onset. If the patient is only positive for IgG, that likely means that this patient had an infection in the past or they were vaccinated. And then if neither of them are positive, that either means the patient's not infected or it means they're very early in the infectious course where they haven't produced antibodies yet. And that might be a situation where molecular testing could be helpful. Another important thing to remember that we're going to touch on a little bit later when we get to molecular testing is that serology can't differentiate between infection and recent vaccination. It just tells you you have antibodies against measles virus, not measles virus from a wild type infection or measles virus that was in the MMR vaccine. When we look at the performance of serology, it performs fairly well, and that's really across different assays. So here's just one study that looked at 350 plasma samples from individuals who had primary measles or reinfection. And in comparison to serum PCR, serology, and specifically IgM, was more sensitive than serum PCR starting at day 7, but performed very similar to serum PCR starting at day 4. Between the assays that were looked at in this study, the performance was comparable between all 4 of them. The only time IgM kind of suffered in its ability to detect measles infection was in those individuals who had measles virus reinfection. There was another meta-analysis, or a study that looked at multiple studies that included over 5,000 specimens from 7 different platforms. And what they found here was that the pooled sensitivity and specificity was about 94% for each of them. And there were at least 3 assays in this study where the sensitivity and specificity was greater than 90%. However, even for those assays that showed very good sensitivity and specificity, there was still a fairly large range for each of those performances. You can see the range here for each of the assays. And that's likely due just because of the different patient populations who were tested and the assay having different performance in those groups. Let's go ahead and round out our discussion of the diagnosis of measles with a discussion of molecular testing. When it comes to molecular testing for measles, we have a few different options with the different patient matrices that we can use. And here's a study from 2001 that looked at positivity rates in different sample types. And overall, what we saw had the best performance was throat swabs. And the performance of that was really best kind of within the first 7 to 10 days from the onset of rash. Another analyte that performed fairly well was urine. Now, something to note about the difference between testing throat swabs, which are traditionally collected in something like VTM, and urine, which is often collected neat, is that with many of the urine molecular tests, it involves concentrating a large volume, maybe 20 mils of urine down before extraction is performed. So some of these tests that use urine as an input may be more technically challenging for labs to bring on. Finally, serum also had a not insignificant positivity rate. The only challenge with testing for serum is that patients tend to be viremic before the rash. So if you're testing after the rash develops, the sensitivity down there is just a little bit lower than if you would use throat swabs or urine. If we look at what the CDC recommends, they state that you should use oropharyngeal or throat swabs. There are some labs that may also offer testing with nasopharyngeal swabs. There hasn't been a lot of good investigation between how those three compare with each other, but probably the most important thing, no matter which of those you're collecting, is that you collect as soon to the onset of rash as you can, because that's when the patient's going to have the highest level of virus in their throat. With different PCR tests, we do have different targets that we can choose from. And here are just some that are present in the literature. There's many more you can go look into, but I just wanted to discuss these three. The first is a PCR target against the N gene. This was a test that was designed by the CDC. It's also endorsed by the WHO. Now, one challenge with an RNA virus is that they can mutate. And so there have been some mutations found in the D8 genotype of measles virus that have some mutations in the reverse primer region for this target. There's also assays using the H gene, which again, we've seen some genotypes of measles virus fail to be detected due to mutations, and then the L gene as well. What's important to remember for all of these PCR targets is just like for our serology test, these targets are conserved between wild type and vaccine strain virus. So if you get a positive result from these, that's not going to tell you whether the virus is vaccine strain or wild type. There have been some studies that have looked at the performance of different measles virus PCR targets, and I want to highlight this study from Stanford that looked at the H, N, and L genes. And overall, what they found was that the N gene demonstrated the most sensitivity, so it detected 75 out of 75 samples across several different genotypes. And that's in comparison to the H and L that performed a little bit worse. And then also the N gene, in addition to being the most sensitive, had the best LOD, so less than 100 copies per mil in this study overall. So the N gene is the one that's kind of been most widely adopted and used at this time. Now I want to present a clinical situation to us. This is a 2-year-old unvaccinated child who was brought to the pediatrician by their parents. And 2 days ago, the child attended a birthday party where one of the children tested positive for measles. The parents were concerned, brought their child to the clinic, and asked to be vaccinated today. The child got their vaccination, but 7 days later, they returned to clinic with the following rash. The provider was concerned that this patient might have measles, and so they tested the patient for measles with PCR. The results came back positive. But the question that we have to ask ourselves now is, knowing that the MMR vaccine contains a live attenuated form of the virus, does this patient who presents with this rash have measles or have a measles vaccine-associated rash? So let's talk a little bit more about the measles virus vaccine strain, sometimes known as MEVA. All measles virus vaccines that are available are composed of this genotype A virus. Genotype A is no longer circulating in the wild. And approximately 5% of individuals who get the MMR vaccine will develop a post-vaccination rash that appears similar to measles. But the important thing to note here is that these individuals who have the vaccine-associated rash are not considered infectious and don't require infection control or isolation measures. So because a patient who has recently been vaccinated will test positive for measles when using a generic PCR assay, we need some way to separate out whether a patient has the vaccine strain or has wild type. And there are two different tools that we can use to help separate that out. One is sequencing. So what we can do is we can Sanger sequence about a 450 base pair region of the N gene. And The advantage of this approach is that it allows us for the identification of the exact strain, so B3 or D8, which are two of the common wild types, or genotype A, the vaccine strain. It also can provide some epidemiological clues about the origin or the outbreak of the virus. The downside of this is that this test is really only available through public health labs, and it has a very long turnaround time. So an alternative to sequencing to detect the measles virus vaccine strain is to do real-time PCR using a PCR that's designed to detect a single nucleotide polymorphism present in genotype A measles virus vaccine strain that's not present in the wild type strains. The advantage of this is that it has wider availability, so this is a test that may be performed at some reference labs. It can also be run simultaneously with the pan-measles virus PCR. So in that situation, not only are you figuring out whether measles virus is present in the sample, you're also figuring out whether that measles virus is wild type or vaccine strain. The downside of the molecular test is that it can't identify other genotypes and that MeVA target has a little bit higher limit of detection. The last thing I want to round us out on today before I wrap up is just to describe some of the data that we've seen from our measles virus PCR assay that we've developed at ARUP. This was a multiplexed PCR assay, so we used both that generic measles target and the MeVA target. This has been designed to be run in an automated PCR instrument, and we launched this test on April 17th. So looking at our volumes over this time frame, we've performed a total of 525 tests for almost 500 patients. This averaged out to about 6 tests per day and ranged anywhere from 1 to 14 tests. Something that was interesting that we saw, this is a 7-day rolling average, but if you look at the daily orders, most of the tests were collected Monday through Friday with very few on Saturday or Sunday. And that probably just indicated that most of our testing is coming from clinic patients who are going to their pediatric clinic for their child with a rash. If we look at the number of positive measles cases we've detected over this time frame, we had a total of 16 positive detections. And what I thought was very interesting was that over half of our detections were from that vaccine strain versus wild type testing. And again, I think this is very important to note because if we would not have provided this differentiation between vaccine and wild type, those 10 vaccine cases may have warranted contact tracing and a larger public health response. But by giving that vaccine result, we were able to reduce the amount of intervention those patients needed. Looking at the age range of people we tested is probably not a big surprise that over half of our testing came from individuals under 10 years of age, and then about 20% of our volume were from kids 0 to 1 years old. The other age groups range from 1% to almost 10%. It's also very interesting if we look at the age distribution of where our vaccine positives versus our wild type positives were detected. So what we see is that for 9 out of our 10 vaccine cases, they all occurred in children 0 to 10 years of age. Again, that age range where you're receiving the MMR vaccine. Our wild type cases were seen in patients 20 to 50 years old, and we did have one case of an immunosuppressed patient who received the MMR vaccine who then subsequently tested positive. We can also look at the CT values and compare CT values between vaccine positive to wild type positives. And what's interesting here and has been observed in other studies is that when we're looking at the generic target, that's the purple signal here, for vaccine strain cases, they tend to have later CT values than wild type cases. And that was what we observed here with a CT of 34 compared to 28.7. We also see, again, kind of correlating that the MeVA target is a little bit less sensitive. We saw that the CT value for the MeVA target in our vaccine positives was just slightly later, about 0.7 CTs later than the generic target. The final 2 pieces of data here are looking at test utilization and turnaround time. So over the span of 3 months while we have molecular testing available, only 13.2% of our testing utilized PCR. And of those, only 4.2% of our orders contain an order for both serology and for PCR, which is what the CDC recommends. So what we're seeing from this data is that we may have an opportunity to improve provider ordering practices to let them know about the availability of PCR to complement serology. And For the patients who did have PCR and serology ordered, overall, we saw the positive percent agreement was fairly low at 23%. Now, this doesn't mean that PCR or serology was worse than one another. What it really just highlights is how the time frame for PCR positivity and IgM positivity are a little bit different. So we're going to have more discrepancies between those analytes. Finally, looking at turnaround time for our test and our PCR, what we saw was that our PCR had a very short turnaround time. So this is from the time the sample was received in lab to the time a result was put out was 27 hours. And this was in fact faster than our serology results. Okay, so we covered a lot of ground today, from the origins of measles virus to how it spreads to how we can control it and how we can diagnose it. But there are 4 things I want you to remember before we wrap up. First off is that despite being the most transmissible human virus, with 95% vaccine coverage, we could eliminate measles. When we think about outbreaks, there's something that really happens at the local level where there's low vaccine coverage, but this can lead to a global impact. And when measles infections occur, it's not just the patient that's put at risk, but the community that can potentially be at risk. And when we think about laboratory testing for measles, it really requires a combination of serologic and molecular testing, and it's essential to separate out vaccine-induced rashes from wild-type measles virus. Thank you again for your time. I'm happy to entertain any questions you might have.
Thank you, Dr. Bradley, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just type your question into the Q&A box below and click submit. We'll answer as many of your questions as we have time for. Our first question is says, thank you for the presentation. Since measles appears so much as rashes, at what point do we know for sure that it is measles we are dealing with and not rashes?
Yeah, so I think that can be a really tricky thing to figure out. And that's kind of part of the reason why I shared that one slide with you that showed how similar they can look. I think when we're trying to make a diagnosis of measles, it's kind of the same approach we need to take for anything in medicine, which is we need a really good patient history. And so that would include things like understanding if this patient has been vaccinated or not, as well as if they've had any known exposures to folks who have measles, or if they've traveled somewhere where endemic circulation was maybe present. The other, I think, important thing here too is that we really do need laboratory testing to help us sort this out, to figure out if this is a measles infection or not. And typically by the time a patient's presenting with a rash, we should have a positive molecular result, or if it's a little bit later in the disease course, that might be a time where we would also use serology and IgM testing to help establish that diagnosis. But it can be very challenging, especially in individuals who have breakthrough cases of measles, so somebody who's been partially or completely vaccinated. If those individuals do end up developing measles, they typically have a slightly different presentation from that classical measles picture. And so, again, diagnostic testing can be really helpful in those situations.
Absolutely. Thank you. All right, our next question here. This question is asking, do you see the current outbreak ramping back up with school starting and the winter months coming?
Yeah, I think it's hard to predict a lot of these things, but I think certainly anytime you have big mass gathering events, which happen over the holidays, also happens when school starts back up and everyone's getting into classrooms again, that increases the risk. And particularly in those school districts, in those communities where vaccination coverage is very low, we kind of highlighted that earlier in the presentation of just how a single case being brought into these communities can really cause very severe outbreaks. And I think if we look at kind of how we've had this downtrending in national vaccine coverage, I think it just becomes more and more common, or more and more likely, that these outbreaks could potentially happen. And in fact, in Utah, where ARUP Laboratories is, we've just had kind of a new outbreak in the southern part of our state that's being centered around the school right now.
Okay, thank you. All right, our next question here asks, in your opinion, how likely are we to see any changes in CDC testing algorithms or vaccination policies as a result of this outbreak?
Yeah, so I think the good news is I think the policies that are in place are very excellent and kind of cover what we need at this stage. It's really kind of increasing compliance, educating those who may have some vaccine hesitancy, and getting the resources that we need into those communities right now to help prevent the outbreaks. We discussed this too kind of earlier in the presentation, but currently, CDC testing algorithms for measles virus do include getting a sample for serology testing. Specifically, IgM is really what we need, as well as that molecular test. And I think for laboratories in the US, molecular testing is not something that was previously available really outside of public health labs and the CDC. So a lot of clinicians who have been trained to diagnose measles have always thought that I need to do IgM. And I think PCR now is a new tool that they need to be aware of. So for laboratories that have some say over how they control their EMR and physician ordering practices, I think if you're seeing an outbreak in your state, if you're concerned that you may have testing needs, this would be a great time for you to kind of reach out to them about the availability of molecular testing if that's something that they would need.
Wonderful. Thank you so much. Okay, our next question here that we have for you is asking, how do you see a diagnostic technologies evolving in the next 3 to 5 years to better support earlier measles detection?
Yeah, so I think the question here is, several-fold. One is that we have a lot of good technology already for molecular detection, and we've been able to scale up that molecular detection in response to other disease outbreaks. We certainly saw how, widespread COVID testing became during the pandemic, how we were able to scale that up. And I think there are some tools for molecular detection that we can, start to bring on in the laboratories. And I think traditionally we've done this by kind of building very manual assays where we're extracting on one instrument, amplifying on another, and then having to read those results out on a separate computer. There are some instruments available now that are able to complete all of that together, do the extraction, amplification, and reporting. So I think we'll see those tests kind of becoming more to the forefront. And I think potentially some manufacturers will start to think about whether the need for measles testing is enough to justify development of assays and submit through FDA to have that clearance or approval available for testing. So I think that's kind of where we're going to see this moving, is that as it becomes easier to adopt LDTs, we'll have more of this molecular testing available. And I think too, there is a role for sequencing. It's less necessary diagnostically, but to track epidemiological trends, again, to track potential mutations that could occur in the virus. So I think also we're going to see a little bit more availability of sequencing for measles virus to begin to develop as well.
Excellent. Thank you. All right, moving along here. Our next question is asking, is there anything laboratorians and physicians do today to better protect their patients and communities?
Yeah, I think this is really just, again, kind of being very focused on education, reaching out to those communities that need that available, and then also making individuals aware of the fact that we do have testing available for measles that they can access through their providers.
Okay, wonderful. Thank you. We have one more question here. This question says, you can't remember how long it has been since being vaccinated. Is IgG immunity testing pretty accurate for determining if you need an MMR vaccine?
Yeah, so I believe the official stance of the CDC right now is that if you are a healthy adult and you know that you have received both doses of the MMR vaccine, you should be considered protected against it. For individuals who may be immunosuppressed, who may be on other medications that can affect their immune system, I think in those situations, it is worth reaching out to your provider to discuss whether you may need testing to see if you have antibodies present or if you need another booster vaccine. But again, there are some individuals who might not be able to receive that booster vaccine. So it is a conversation you'd need to have with your provider about some of those specifics. But in general, we're thought that once you get both your vaccine doses to measles virus, you have lifelong immunity. There have been studies that have found circulating antibodies 35 plus years after. And there's also been some data to suggest even if you don't have IgG antibodies detected by ELISA or whatever method you're using, it may just be that that antibody level is kind of below the limit of detection for the assay. But for those individuals who get re-exposed to measles virus, if they do have a history of vaccination, even if they don't have detectable antibodies, they do mount a much more rapid immune response and tend to fare better against infection. So it's a little bit more nuanced, but yes, in general, we think that there's lifelong immunity from the vaccine.
Wonderful, thank you. And that is all of the time that we have for questions today. So I want to thank you again for your time today and your important research. We would also like to thank LabRoots and our sponsor, DiaSorin, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay, and we encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Goodbye.